delirium piece and reducing sedation has been reasonably easy to implement. The mobility is the hardest part because it requires resources, it requires nurses to understand what you're doing and to change their workflow and to actually implement a protocol. So we have a protocol which is much like the standard protocol in the literature, which is assess the ability to mobilize and then do a progressive mobility program, which starts off with passive range of motion, active range of motion, sitting in bed, dangling over the bed, and then trying to walk them. So we have a protocol which our nurses are meant to follow. They try follow it, but I think it's they struggle with it, firstly because, for a number of reasons. First, they're really busy. They're doing a lot of other stuff. They may not see its entire value. Secondly, we have a really obese group of patients, and I think that mobilizing and moving obese patients is logistically quite a difficult task. The goal is to walk them on a ventilator, which is such a bizarre concept if you don't know it and if you don't know the data. I think that piece is difficult to operationalize. You need a big team, but it's an intangible outcome which is difficult to show to a hospital CEO. So, I give a lecture on mobility and people say, wow, this is the best thing in the world. We've got to do this, but it's really hard to operationalize. So our nurses try. Nurse manager understands how important it is, and they do the best they can. But I must be honest with you, it's not ideal. We need better equipment, better technology to help us achieve this, because it's difficult. These are patients that are in bed, they're weak. There's always the question about patients falling and injuring themselves, the safety aspect. So the walking part on a ventilator, when you see the videos, it looks pretty cool, but I think it's quite difficult to implement. You really need a dedicated team.